I can tell you, for example, the date of discharge is a very subjective matter because it depends whether you have fast track programs or not. It depends on the social conditions of the patients. But in fact, for a patient like this to be home at day 11 in the condition that he arrived was quite good for us in our center. And so we actually published the first 3 patients in our center with the first 3 patients in Italy, again with my friend Fabrizio De Benedetto from Modena. And it's interesting to see, these are some of the incisions of the first patients. We modified all this, and I will explain what we're using now. Now we are using a lower midline incision, and we are keeping the robot docked the whole procedure, and this saves a lot of time. But you can see here, when you see the results, you can see the first 6 patients. In fact, you have a warm ischemia time in some patients of 90 minutes, some of them 70, 55. But still, what you can see that in most of the patients, estimated blood loss was low, ICU stay was rather low, and hospital stay in some patients was like 4 or 5 days. Of course, very well compensated patients. So this was the beginning of our experience. This was just, in fact, this publication, I would say, this was published in Annals of Surgery, January 2025. This was more a proof of concept than showing that robotic liver transplantation is, in fact, a better technique than open. We don't know that, actually. But we are gaining experience and we can have some insights about some advantages. So our patient selection at first was a MELD of less than 25, mild to moderate portal hypertension, small to moderate liver sizes. Ascites was good. A BMI of less than 35 was preferable. Small donor grafts. We avoided patients with previous TIPS, previous surgery, ALF or ACLF, severe portal hypertension, and familial amyloidotic polyneuropathy. I can tell you that now this is gone because we do all this. We do previous TIPS, we do previous surgery, we do acute liver failure. I did, in fact, a patient with acute liver failure last week, and the operation took 4 hours from skin to skin in an acute liver failure patient that is doing very, very well for a heat stroke. So we have problems, and this is important to be said. For example, our 5th patients, we decided to change the team, and I became the surgeon assistant, and my second, the vice chair, that is also a very experienced robotic surgeon, was performed the robotic hepatectomy. And in fact, what happens is that when I apply the stapler next to the IVC, I cause the stenosis of the IVC. And this caused an outflow problem. And this patient had to be retransplanted. We had to leave a laparostomy in the reoperation. The patient did well, but still it was a drawback that was a setback that was totally related to the technique. This is another example. In the 7th patient, we had an unexpected portal vein thrombosis. And this patient, in fact, was submitted to thrombectomy. It was okay. In the end, we considered that the flow, in fact, was not very good. And we ended up doing the anastomosis in a varix to the left gastric vein. You can see this flow was not acceptable. So we went to a left gastric vein. And in fact, this patient was converted due to bleeding, not because of this, but because of the IVC anastomosis. This is one of our conversions. This is a recent patient. As you can see, I can tell you this patient is a patient with a MELD of 35. The patient had a previous portal vein thrombosis that was anticoagulated and recovered partially. This patient had an episode of bleeding 2 weeks before, but still we decided to perform robotic liver transplantation. And I'm going to go back again just to show you. This is what we saw in the beginning. This is the round ligament. This is the total hepatectomy. We do it always from left to right. We avoid mobilizing the liver only in the end. This is the artery. You can see here, this was a patient also in a very bad condition, in fact. This is the bile duct. This is the portal vein. And this is exactly what we do now. This operation has maybe 2 months. So mobilization of the left liver, mobilization of the right liver. You can see the liver here. Portal vein is gone. Middle and left hepatic veins, right hepatic vein. Total hepatectomy is performed. A caval clamping, partial caval clamping test is done. And we are now doing an implantation here with partial caval clamping using Gore-Tex. We are now using more and more the Prolin stitch that we usually use in open. So hepatic vein anastomosis is finished. We go to the portal vein, and you can see here the portal vein actually had a partial thrombus. It was not a problem. So the posterior face of the portal vein, then the anterior face of the portal vein here, and then flushing, and then perfusion. And you can see here very nice reperfusion. We close the portal vein, have a very nice flow. We didn't have, in fact, a lot of bleeding. This is the artery. You can see here that we are now using a totally different set of instruments. I can tell you that as we are speaking, my team is doing the implant of the robotic graft that we just did in the next room. This is the artery being done. This is a small stitch to straighten the artery. In fact, it was a little redundant. Cholecystectomy. This should be done before when possible. And you can see here the bile ducts. Anterior part of the bile ducts. And the operation is in fact finished with no major problems, as you can see here. Not a lot of bleeding and a very high quality reconstruction that you can check by intraoperative ultrasound. This is a portal vein. Here's the flow of the hepatic veins. This is finished. So as you can see here, we had 5 hours of consult time, 41 minutes of warm ischemia time. Warm ischemia time is getting close to 35 now, but sometimes 40, sometimes between 35 and 40 is what we are getting right now after more than 40 procedures. 50 minutes of portal clamping time, 1 unit of red blood cell, and this patient was discharged at postoperative day 9. And I can tell you this patient also arrived in a pretty bad condition. So this didn't come by accident. I think if you look at this, why did we do this? In November 2009 was our first left hepatectomy, was patient number 5. Our first central hepatectomy was done after patient number 47. Our first hepatectomy for Klatskin was done after 176 patients. Our first full graft deceased donor liver transplant was done after being done more than 321 patients. And the first robotic donor hepatectomy after 371, the first full robotic living donor after more than 500 patients. And finally, very recently, we started to have a second surgeon that is prepared to do robotic living donor operation, recipient operation, and we did 2 simultaneously in 2 different platforms in March this year. So this implies a pretty good experience. And this is what we presented at the European Surgical Association this year. Outcomes after the first 45 patients. This is robotic whole graft liver transplant, the experience of Lisbon and Modena. And in fact, Lisbon and Modena altogether presented at the European Surgical Association in Rome 22 cases each, because one of them was converted, but 22 cases from Lisbon, 22 cases from Modena. You can see here the vena cava clamping time around 69 minutes, portal time about around 60 minutes,